Good morning, everybody. That was Journey, and everything we hear today will be from Journey. And I'm Dr. Minarsik, taking a journey with you. I kind of cut myself shaving this morning, so I feel kind of self-confident about it. Today is August 20th, 2019. It's 9 o'clock in the morning. This is our sixth webinar of the year. We had a special one which you didn't go to, just strictly for the students at my medical school. But this is our sixth overall webinar for the complete course of medical school pathology, academic year 2019-2020. Today, the graphics theme will be tigers, as you can see over there. And I think we should also do our AVM test for those of you who have been here before. You know it's very, very important. The A stands for audio. So in order for me to know that my audio is working, I'll ask you the question, can you hear me well? If you can, type in the answer. Hopefully you can. Everything here looks like good. Second question is, how many fingers do I have up? That's not a yes/no question. Okay, good. Third question is, on a scale of 1 to 10, what was the quality of the music that you just heard from Journey? I'm hoping to get high numbers, but I'll settle for honesty. Okay, well, I'm getting sevens. Maybe we can make it a little better next time. I don't know. Okay, the topic is going to be hemodynamics, and I made the comments, oh my God, finally we're going to learn some real clinical stuff. It seems like a lot of the path we've learned so far at the beginning has been very theoretical and non-clinical, but this is a very, very clinical chapter, and I'm very glad to have it. These are all of the things we're going to be discussing today, so if you can memorize that right now, you could go home. Oh, whoops, you are home. I'm sorry. How about if we close the ugly guy and put up the PowerPoints and get down to business now? What we will do is talk about the topic of hemodynamics. And here we go. This would be originally Chapter 4. It's always a very, very important topic in pathology. And it's also the first real clinical thing. Hemodynamic disorders. I'm going to start out by throwing that complicated equation at you called the hemodynamic disorders Stirling-Landis equation, which basically shows why fluid goes in and out of the extracellular space. But we'll get into that later. The actual topics that we'll be dealing with today and also 2 days from now on Thursday are going to be generally hemodynamic disorders, not hematology, not what happens to the red cells, but what happens to the flow, what happens to the fluid inside of the blood vessels. Where does the water go? Where do the blood cells go? Things like that. If there's too much flow, if there's too little flow. We'll be talking about thromboembolic disease and maybe a little bit the opposite of this, bleeding disorders. And we'll be talking about things like infarcts. And finally, the worst of all hemodynamic disorder to have is not enough total body blood flow, which is what we call shock. So I think as long as we're going to be starting on a 2-day journey, we should generally know the precise and correct medical definitions of all these terms. Edema, as you know, is an increased fluid. It's in the water compartment called the extracellular space or extracellular fluid. It's not in the cells, it's not in the blood vessels, but it's in the space between the cells and the blood vessels. Increased fluid is called edema. Hyperemia technically is what it might sound like. It's an increased flow of blood. Congestion is increased backup of blood. So if you're looking at blood vessels and they look like they're very prominent, they may be prominent because they're getting too much flow, or maybe they're not being drained quickly enough through the venous system. Hemorrhage is extravasation of blood. Hemostasis is one of the trickiest words in the world, and I've had trouble with it for years, but you could think of hemostasis as the opposite of thrombosis. So thrombosis is the clotting of blood or the formation of blood clots. Hemostasis can be thought of as being the opposite, the preservation of liquidity and flow of blood. Okay, I don't like the word stasis, and that often implies slow or sluggish flow, and sometimes it's used in that respect also. An embolism is the downstream traveling of a blood clot, whether it's downstream arterial or downstream venous. An infarction is a tissue or an organ or a part of an organ that has died because of lack of blood flow, lack of oxygen, and that has certain appearances, both grossly and microscopically. Finally, the worst of all possible hemodynamic disorder is shock. Why would you have lack of total body blood flow? Well, maybe your heart just isn't strong enough. Maybe the volume has decreased drastically due to hemorrhage, or maybe there has been the presence of certain inflammatory reactions caused by, let's say, bacteria, what they call a septic shock, which many people die from terminally, which have just made an entire cardiovascular collapse. That's probably the best definition, is circulatory failure or cardiovascular collapse. So these are all the proper terms. And let's start out with the first one, edema. And that's what our little equation was like, our Stirling-Landis equation. And when you think about it from a pathophysiologic point of view, there's really only about 4 reasons why I could think of where there is a shift in fluid, either from the cell to the extracellular space or the blood vessel to the extracellular space. Think about it. If you have increased pressure in the venous, not the arterial, but the venous side of your blood, that hydrostatic pressure can overcome the drawing in pressure called the colloid oncotic pressure, okay? So if you have increased hydrostatic pressure or reduced oncotic pressure, that would be a most common reason for most types of edema. Let's say that you had obstructions of your lymphatics, which of course drain the extracellular fluid. If there's a disease to them, like they're filled up with tumor or they've been irradiated or they've been surgically interfered with, that would result in increase of extracellular fluid because the lymphatics drain the extracellular fluid. Finally, physiologically, you know, the old principle in physiology is where the sodium goes, the water goes. So if you have increased sodium in any compartment, then that would result in increased water, okay? So sodium retention is associated with water retention. I'm going to show you that equation pretty soon again, and maybe we'll even go back to this because I think it's a very simple concept, okay? Water itself, as you know, 60% of your body is water. Most of it is inside your cells, 2/3, but the rest is between your cells, interstitial. And there's only a small amount, believe it or not. If you remember, your blood volume is what, a few pints, let's say. That's only 5% of your water. So edema is a shift to the interstitial fluid space or extracellular fluid from either direction. It could be coming from the vascular compartment or it could be coming from the cellular compartment. If another definition is if you have increased fluid in the thorax or in the pleural cavity, that would be called hydrothorax. Or if you or most people would probably call it a pleural effusion, okay? If you take that other mesothelial line space called the pericardium, if you have increased fluid there, that would be called hydropericardium, or most people would call it a pericardial effusion. Similarly, the third mesothelial lined body space, the peritoneum, an increase of fluid or water there would be called hydroperitoneum. but nobody calls it that either. They all call it ascites. So these are definitions. The other definition I want to introduce to you is something called anasarca, which is generally seen in a term that's used to that often in severe protein deprivation, starvation, seen as basically total body edema. Perhaps all three of these body cavities and just tons of it in the interstitial space as well. So why would you have increased hydrostatic pressure? And hydrostatic pressure is like real pressure, okay? It's like the pressure inside of a pipe or the pressure inside of your artery or your vein. When the pressure inside of your veins, venous pressure, exceeds the colloid oncotic pressure, remember, the colloid oncotic pressure is the pressure that is due to the presence of solutes, or we'll call them protein solutes inside of the blood vessels. That has a drawing in effect, just like anything that has a solutes might draw in something, even in chemistry. But when the hydrostatic pressure in a vein exceeds the oncotic pressure, usually due to impaired venous return, whether it's heart failure, whether it's a pericarditis and unable to return, whether it's an ascites, whether it's obstruction of the vein, or perhaps compression or thrombosis, or even a mass pressing on a vein. Or let's say that you just have not had the opportunity to draw or exercise your calf muscles because you've been bedridden for a long time. You no longer have that ability to pump that venous blood from your lower extremities. Technically speaking, arterial dilatation would be a factor as well. You know that heat would result in increased hydrostatic pressure, as well as perhaps inflammatory changes and even disease to the blood vessels. And finally, the last thing I'll throw in, because in my opinion, it's never really given as a practical reason for increased hydrostatic pressure, but you know that veins, mostly arteries, but even veins, have certain degree of autonomic innervation, and if there is a problem with that, that might result in increased hydrostatic pressure as well. Why would you have reduced plasma oncotic pressure? Well, think about it. Your plasma oncotic pressure is due to the presence of the proteins in your blood, and almost probably chiefly albumin, because it's the major protein and it's the major, we'll call it a protein solute. And on the basis of your blood being a solution of both fluids and proteins, that has a drawing in effect. I think that's easy to understand if you remember that something that has salt in it will take in water. Well, something that has the solutes of protein in it will also take in water. Well, what happens if you're losing that protein because it's leaking out through the glomeruli? That's a reason for hypoproteinemia and reduced oncotic pressure. What if you have cirrhosis? Because remember, the liver is what makes the albumin. So in a cirrhosis, you have reduced oncotic pressure. Added to the fact that in cirrhosis, you may also have hypertension in the portal system, another reason for showing increased pressure in the veins, the portal veins. And malnutrition can be thought of as the same thing. But let's say that you are losing your proteins because of inflammatory disease in your bowel. We talked about losing it through the glomeruli or the kidneys, but you can also lose it through your bowel if you have inflammatory bowel disease or other ulcerative, let's say, diseases resulting in leakage of blood protein into your gastrointestinal tract. Okay, let's say we talk about lymphedema now. It's not only the extracellular fluid that goes into the veins. The presence of extracellular fluid in the interstitial space is also picked up by the lymphatics, okay? So what would happen if your lymphatics were inflamed maybe there was a lymphadenitis or you had an inflammatory localized thing. Well, it couldn't drain the fluid then, couldn't, and that's called lymphedema. Let's say they had tumor loaded within your lymphatics and your lymph nodes as well. Well, that would be another reason for lymphatic obstruction. What happens if there's been extensive traumatic surgery to a region, classically the axillary lymph nodes, and the lymphatics that supply them? Well, that would be another reason for lymphedema. Probably the most common type of lymphedema you would see clinically is post-mastectomy lymphedema, which has become a lot less prominent than it was before simply because of less invasive breast surgery. Or post-irradiation. Think about it. If you irradiate a vessel, a lymphatic vessel, a group of lymph nodes, then that's going to result of fluid building up also. Sodium retention. Well, where the salt goes, the water goes. So think about it. Could you have sodium and therefore water retention strictly on the basis of excessive salt intake? Yeah, theoretically you can, but it's very, very rare. Most of the sodium retention you have is renal caused because of increased tubular reabsorption. Okay, the sodium goes back into the blood, but probably the thing that also causes sodium retention is one of the main pathophysiologic factors in hypertension as well, because as you know, decreased blood flow to the kidney, whether it's due to kidney disease or congestive heart failure, which is probably even more common, it increases your renin, which then kicks in the angiotensinogen 1 and 2, ultimately also kicking in the aldosterone, which, as you know, excretes potassium. Okay, so that would be another reason. Your plain old RAAS, renin, angiotensin, aldosterone axis, which I wouldn't be surprised if you spent like a whole day on last year when you took regular physiology. Another reason for edema, we talked about this in the last webinar or so, would be acute inflammation. Remember, we said the 4 cardinal signs of acute inflammation were redness, calor or heat, dolor or pain, but T for tumor. Well, the tumor or the swelling, not really a tumor, but the swelling that you get with acute inflammation is strictly on the basis of localized hyperemia and leakage of stuff from the vascular space into the extracellular fluid. To a lesser extent, chronic inflammation, things that are chronically inflamed are not as swollen as things that are acute inflamed, but there may be a small component to it, especially if there's some residual of acute inflammation with it. And angiogenesis, if you remember, the intermediate phase between inflammation and healing is something that we called angiogenesis or neovascularization or granulation, and that's just because what follows inflammation is increased amount of blood vessels, and with an increased amount of blood vessels you would get an increased amount of fluid as well. Okay, let's go back to that equation which you saw on my door, and I don't know if I did a good job, but you know, I'm going to show it to you again because this is so important, and it summarizes everything that we just talked about. You see that bad boy over there? That's what I decided to write down today when I was a little bit inspired. When there is an increase in hydrostatic or pure pressure, like pipe pressure, and it is greater than the oncotic pressure, which is the drawing in of fluid, whenever the hydrostatic pressure is greater than the oncotic, or the forces that want to make fluid leave the cell are greater than the forces that want to draw that fluid back in. And I'm sorry, then you have something called edema, okay? And that's usually at the arterial end, because as you know, the arteries have greater pressure, and they also have you know they have greater pressure because they have a thicker wall, so they have to have greater pressure. And then you have your capillary part of your circulation, in which the hydrostatic pressure is about equal to the oncotic pressure, so there is no net flux of fluid in or out. But on the venous end, you have a lot low oncotic pressure, and you have much lower hydrostatic pressure, and your oncotic pressure is now a bigger factor than your hydrostatic pressure. So the net flow, which is called JV, or if you want to call it the net flux, would be back into the veins. Now there's another little thing that complicates this equation, but it's a big factor, is these lymphatic vessels here, these thin-walled structures, which are literally riddled throughout the body, also have as a function the job of picking up extracellular fluid and draining it into the lymphatic system, ultimately back into the vascular system. So that's the Stirling-Landis equation, and I tried to explain it in plain words and concepts rather than make you think this is a physics class or something like that. Let's do it again. At the arterial end, the hydrostatic pressure is greater than the colloid oncotic pressure, so the net flow of fluid is out of the vessel. At the capillary end, the forces are about the same. You know that the hydrostatic pressure has to be less because you no longer have that thick, high-pressured blood tubule. Then finally, in the venous end, the colloid oncotic pressure, which technically is the same throughout your entire vascular system, but now it has a greater drawing in effect than a pushing out effect. And here are your lymphatics, taking it all the way ultimately to the left subclavian vein, the thoracic duct, subclavian vein. And that's the main concept for just about all the types of edema we just talked about. Okay? Whoops. Why would you have edema with heart failure? By now, it should be kind of obvious. If the heart fails, that means it can no longer follow the other law of the heart by Stirling, the Frank-Stirling law, which says the heart will pump out whatever the venous return gives to it. That's a really great principle, and that's another Stirling law of the heart. But if your heart failures, it cannot pump out the venous blood that is giving to it, and therefore there's increased in venous pressure. Now think about it. If it's primarily a left heart failure, you're going to have increased venous pressure in the pulmonary veins, aren't you? And the pulmonary capillaries. If it's a right heart failure, you're probably going to, the brunt of your increased venous pressure is going to be systemic rather than pulmonary. But another factor that is equally important is the concept of, in a failing heart, you now have decreased renal perfusion. And you know what that kicks in. Once you have decreased renal perfusion, it triggers off the renin to activate the angiotensin-aldosterone axis, which is ultimately resulting in sodium retention and potassium excretion. So these are two reasons for edema in heart failure. And edema in heart failure is one of the three main things that are present in basically all types of heart failure. Okay? Why would you have edema with liver disease or cirrhosis? Well, one reason why you would have localized edema in the organs that are parts of the portal drainage is simply because the liver is now scarred down. And if you can think of the liver as nothing more than a filter between portal blood and caval blood, when it's scarred down, you build up that pressure. Just about everybody with cirrhosis or severe end-stage chronic liver disease, whether you want to call it cirrhosis or not is up to you. will have portal hypertension. Okay? But also, remember, the liver makes the albumin. The albumin in your body, which is the main component of your colloid oncotic pressure, is now decreased. And that means your colloid oncotic pressure is decreased. And now there is no sucking in effect of fluid. Okay, so those are two reasons now for having edema, either localized to the portal system or systemically. Okay, and what about this? I think you all know what this is. This is something which is the result of severe portal hypertension. Okay, this is ascites. This is increased fluid inside the entire abdominal cavity. And I know what you're thinking. You're thinking, well, this is just a picture. How do you know this just isn't a fat person or a pregnant person? Well, when you get up to the clinics and internal medicine, you're going to see a lot of this. And you're going to put your hand on one end of this big basketball here. And then you're going to be tapping the other end. And you're going to feel the fluid going through. Of course, that's just a clinical way. Nowadays, this person would get CT and MRI. But just remember, the old test for fluid wave in your patients is a great way to differentiate this from just obesity. Okay? Why would you get edema if you have kidney disease? Well, let's take the easy one first. Well, they're both easy to understand. One of them is that in many types of kidney disease, particularly the glomerular kidney disease, there is problem with the glomerular basement membrane. So now proteins are actually leaking through that basement membrane, and you develop a hypoproteinemia. And it could be so severe as to cause a nephrotic syndrome, in which not only do you have massively increased protein in your urine, but massively decreased protein in your blood volume, okay? And that would basically wipe out your colloid oncotic pressure as well. The other thing is sodium retention. Many types of kidney disease are going to result in increased tubular resorption of sodium, and therefore hypernatremia in itself would also indicate hyperwater as well. See, I told you this was going to be very clinical. Let's take some of the classical adjectives or types. I don't want to say the word type, but we'll say adjectives of edema. Okay? Sometimes you'll hear the word pitting edema, which is pretty much synonymous to subcutaneous edema. So let's say that you have a swollen foot because you have heart failure, or you have puffy eyes, whatever. You put your finger on the skin and you press it in, and it pits. In other words, there's a little impression that'll eventually come back in a few minutes, but that's what you would call pitting edema. Pitting edema. And often this is a nice clinical test you could do with your heart failure patients by simply pressing your thumb into the dorsum of their foot every morning when you come to see them. And depending on how much pitting there is, it might be a clinical indication of how good your treatment is for their congestive heart failure. There's also a term called dependent edema, and that's simply due to the fact that the lower extremities, which are the most gravitationally dependent portion of your venous system, if there is a lack of return in those because of prolonged bed rest or some problem with the valves or varicosities or lack of exercise, then that's going to result in an edema as well. We said that the word anasarca, and it's very possible you'll never see anasarca in your life, but the term anasarca is extreme total body edema, very often due to starvation, severe liver disease, protein wasting disease, in which basically you could say all of the compartments of the body where there is fluid are increased. That's basically a very, very serious, often pre-terminal event. Also, think of edema as being due to either left or right heart disease. If it's primarily the left side of your heart that's failing, the veins that supply the left heart, the pulmonary veins, are going to show increased pressure, and therefore you're going to have congestion and even edema inside of your lungs. If it's primarily a right heart failure, then of course the veins that supply the right heart, the systemic veins, basically everything but the lungs, might show some degree of edema. But this is a very important concept in medical school. But really, in real medicine, they don't normally say the patient has pure left or pure right. Usually heart failure is really kind of shows features of both. And when you see when you hear somebody talk about heart failure, they usually do not differentiate left or right. Periorbital edema. Well, what does that mean? It means that there's edema in the soft tissue surrounding the orbit. You can see it there. And why was that important? Well, there could be a lot of things causing it, but just as an association for some reason, which is still kind of unknown to me, even though any of the forces that cause edema can cause this, it's very, very often seen in the edema due to renal problems. So when you see a patient with particularly a lot of edema, you might be thinking kidney, although technically many other things can cause it. Pulmonary edema is technically right heart edema, okay? Cerebral edema. Well, this is an interesting topic because your brain can't swell because it's inside of a big walnut shell. So how could you have edema and things swelling if there's no space for it to swell in? Well, I'm going to show you a few things that are going to show that. And even though I have put things down here, there are tiny little areas in the brain that are basically areas where there are potential holes, or where rather than having hard bone, you have dura, where there could be herniation or compression of those softer areas, like the tentorium, the falx, and of course the cerebellar tonsils, in which this case it's basically the foramen magnum, which is the potential hole. In these cases, these are just dural membranes like the tentorium or the falx. Okay, pitting edema. Press your thumb on a swollen foot and look at that little thumb impression stays there. Not forever, but maybe for a few minutes. Okay, that's because of foot edema or dependent edema, if you will. Or if this was a patient in heart failure, maybe you would think this would be more right-sided failure rather than left, but it could basically be in just about all types of heart failure. And remember, when we talk about edema now, we're talking about basically pure water, okay? It's what we call a transudate. It is not loaded with protein. It is not loaded with cells, unless there has been some damage to the blood vessels as well. So a transudate is basically pure water. It results from disturbance of these so-called Starling forces that we showed you the equation of. So it has a very, very low specific gravity, almost 1.0, which is what water has. And it has a very, very low protein content. And it has basically no or very few cells, okay? Now, in the exudate, in which there now has been damage to the vascular wall, you have a higher specific gravity. Okay, now it's over 1.0. And because the proteins are leaking out, the exudate now has a lot more protein than the transudate. And technically, if it's not just proteins that are leaking out, but it's cells that are leaking out, if you take it to the lab, they're going to tell you that there's a lot of cells. And cells have the enzyme LDH, so they might actually have a good amount of LDH activity inside of the exudate as well, in which there should be practically none in the transudate because there's no cells. Another thing to remember is that there is a difference between the pathophysiologic concepts of hyperemia and congestion, okay? Even though these terms are often used interchangeably, and they may look very, very similar pathologically or histopathologically, technically hyperemia is an active process in which there's increased flow, hyperemia. Now, congestion might give a similar appearance of, dilated capillaries, let's say, not because of increased flow, but of decreased emptying on the venous side. So those are two important concepts to remember. However, when you are looking at organs of a patient, let's say, that has congestive heart failure, all you see basically are perhaps dilated veins or leaky veins, and you don't know if it's because of increased active flow or decreased passive emptying. So there you go. Hyperemia, an active process. Congestion is a passive process. And why am I doing that? Because I'll tell you why I'm doing that in a minute. So, congestion, would you want to call it hyperemia or congestion? Well, technically it's congestion, but a lot of people call it hyperemia. If you had theoretically a right congestive heart failure, think about it. The pulmonary veins cannot be taken care of in terms of supplying the heart. And now you have increased pulmonary vein. You also have increased pulmonary capillary wedge pressure. The cardiologist will tell you that. And you will have increased dilated, not only hyperemic pulmonary capillaries, but they may leak out the blood and they may leak out the fluid as well. So if it's prolonged, it may become chronic. Not only might you have increased fluid there, but you'll have increased blood cells that have leaked out of the capillaries. And what happens to them? Well, they eventually have their hemoglobin broken down through this basically chemical degradation, ultimately to a product called hemosiderin, which still has the iron in it. And of course, the hemosiderin is now in the macrophages, whereas the hemoglobin was in the red cells because the red cells have broken down. Now, what about in the liver? Let's say that technically you had a left congestive heart failure, and one of the organs that feeds the left side is the liver. Well, if you remember, the central veins give rise to the hepatic veins, which basically give rise to the cava, ultimately the inferior vena cava. So it's going to be more congestion in the central veins, which is in the center portion of the hepatic lobule. So that's often called centrolobular congestion, or even central lobular hyperemia, but that word is hardly ever used. If this process continues or worsens or becomes chronic, now that central portion of the lobule, in which the central vein is in the middle, can become necrotic because of decreased blood flow. And remember, the central portion of the lobule is not oxygenated nearly as well as the portal portion of the lobule. So it's the first to become necrotic if there's decreased or chronically sluggish hepatic blood flow. And in the brain, we're going to show you some interesting pictures. Okay, there's a lung. There's a normal lung. Okay, look how thin those alveolar septae are normally. Look how they become not only thicker now, and the reason why they're thicker is because the alveolar capillaries are congested, because the pulmonary veins are sluggish, because they have increased hydrostatic pressure. And now, not only do you have dilatation of these pulmonary alveoli, these alveolar walls, but they can leak out fluid and cells into the alveoli. So here you go, I'll make this simple for you. What is the difference between this and this? Well, the difference is these spaces are air and these spaces are water, if you want to think of it from a very, very simple point of view. And of course, there could also be more cells inside the alveolar as well, particularly red cells, which ultimately break down. Here is a classical view radiologically, which you might see on your patients of acute pulmonary edema. Think about it. If your alveoli have more water than air, they're going to look denser on x-ray because now you're talking about a water density rather than an air density. And because very often this would be more in the dependent portions of the lung due to gravitational things, you basically see what they would call, any radiologist would call generally an infiltrate. Now, infiltrate basically means increased density. Could this be pneumonia? Could this be tumor? Well, it's kind of diffuse, and it's the entire lung. So if this patient was in heart failure, they would probably just call it pulmonary edema without even blinking their eyes. Okay? If this is pulmonary edema, think about it. When you have the bronchi here, okay, normally a bronchus is air surrounded by air, right? But now, let's say you have a bronchus which is still air, but it's surrounded by water, because you now have water in the air spaces surrounding the bronchi. So that's why it's become more prominent, because now you have a air-water interface rather than an air-air interface. Another thing is that if you look peripherally in the lung, often at the bases, you have edema within some of the septate regions of the lung, okay? These are called the curly B lines. And they're not called curly because they're curly. In fact, they're not curly. They're straight, okay? But I guess Curly was a radiologist who discovered them. I should probably look that up more. So if your patient has heart failure and you get back a radiology report of curly B lines or air bronchobands, there's even other things they call like a Batman sign because it looks like it's kind of symmetrical. You know, that's a classical chest x-ray radiologic appearance of heart failure. Now what's this? Well, what if I told you it was lung again? But now many of these air spaces, they don't have in fluid, they have cells. And the cells have little pigments inside of them, which might be hard to see. And these cells, if you look at them, they are mononucleated. So these are macrophages. So why would you have pigmented macrophages in the alveoli of a patient with heart failure, particularly, let's say, left-sided heart failure? Because now these congested vessels have leaked blood cells, and it's being picked up by these scavengers of the lung called the pulmonary macrophages. In fact, think about it. If your patient was in heart failure and had some degree of chronic pulmonary congestion and edema, and you took a sputum sample on him, some of these pigmented iron macrophages would actually be in the sputum. And the old name for them, or the name that's still used, are called heart failure cells. Only now they would probably just call them hemosiderin-laden pulmonary macrophages. And you could prove that it's iron or hemosiderin, because hemosiderin contains the iron pigment, and there's a stain that is fairly specific for hemosiderin or the iron in hemosiderin. It's called the Prussian blue stain. And this is just to show you that in this chronically in this chronically congested lung, you now have pulmonary macrophages. I'm going to show you this thing too. Whoops, next one. I love this picture the most. And I think probably most of you have recognized by now that this is probably a liver. Okay? And you can see some big veins. And it looks like some of the veins might have a little connective tissue around them. And it looks like some of the big veins don't have any connective tissue. Well, the big veins that have connective tissue are probably the portal veins, because remember, they have to have a vein, an artery, and a bile duct. And that's probably a bile duct there, I think. But if you have a big vein that is surrounded by no connective tissue, that's probably a hepatic vein. But you want to know the really, really cool thing about this? if you look carefully, you see that red dot over there and there and there. Every one of these little white areas has a red dot. Those are actually the central veins. So if you thought the only way you could ever see a central vein in histology is to look, through a microscope, you're wrong. These are individual central veins. And why are you seeing them? Because they're congested. Why? Because they drain into the portal veins. And the portal veins drain into the inferior vena cava. And the inferior vena cava cannot be emptied fast enough by the heart because there's increased hydrostatic pressure. So this is what an acute passive congestion liver would look like in heart failure. And if you want to say right heart failure rather than left heart failure, that's okay too. Now, what do you think would happen if the central portions of these lobules were congested chronically or prolonged? Well, it means they're not getting enough blood. So the central portion of the lobule would become necrotic. But the portal portion of the lobule would not become necrotic because, remember, it has that little thing called the hepatic artery branch, so it's oxygenated better than the central portion. And I think I have a nice picture of that. And there you go. Take a look at the veins here that, like here, that has no connective tissue around it, so you know that's a central vein rather than a portal vein. And look how redder it is, how it's congested around it, and probably this one too. But the portal veins, the larger portal vein areas, maybe that one and that one, look like they have more viable cells because they're not necrotic. Okay. And here we go. Chronic passive congestion in the liver. We can now see necrosis in the central portion of the hepatic lobule, which the pathologist would call central lobular necrosis, seen with chronic passive hyperemia, or technically congestion in the liver. And by the way, this would not be a pathology course if I didn't show you this picture, because this picture has been showed in every pathology course in the world. Does this look like the liver I just showed you? Well, actually, it's a nutmeg. So the liver of chronic passive congestion of the liver is often called a nutmeg liver microscopically, or grossly even. And guess what? What was I going to say? Well, maybe I'll say it later. What's this? Well, this is my friend Matt. He's a lawyer. He's one of the most prominent lawyers in Chicago. And here he is looking at you. But I asked him to stand in front of a window and press his face against a window and look at me with his face pressed against the window. Well, here, his lips are round, his nose is round, but when he looks at me with his face pressed through a window, everything is flat. So let's say that his face was really a brain. And you have these nice round, curved gyri, okay? But now they're pressing up against the cranium because the brain is edematous. Now the gyri are more flattened, okay? See how it looks more flat over there? That one looks kind of round, but in that area it looks kind of flat. So that's why the neuropathologists and the neurosurgeons will tell you, and the radiologists will tell you, that if you see flattened gyri, that's probably the result of increased fluid in the brain or cerebral edema. But remember, not all of the brain, not all of the cortex is inside of a walnut shell. If you remember, some of it is bounded by less rigid dural membranes like the falx or the tentorium, separating the middle from the posterior cranial fossa, or even the foramen magnum. So very often, if there's a unilateral edema, it might cause a subfalcine herniation because the falx extends to the corpus callosum and there's nothing there that stops it. So it technically is a potential hole or potential space. If you remember, the medial aspect of the tentorium is also just a fairly firm flap of dura, but it's not bone, so you can have herniation of the cingulate gyrus, okay, of the hippocampus. Or technically, if you had increased pressure inside of the cerebellum or the infratentorial structure or the posterior cranial fossa, you could have some herniation of the inferior part of the cerebellum, the cerebellar tonsils, also through the foramen magnum. Now that would be pretty bad because now you're pressing on the most important part of the spinal cord. Okay, are we going to say anything more, or are we going to take our break? Yeah, we're going to take our break because now we're going to go into a big topic in the second half called maybe like hemorrhage and thrombosis. So I think we covered about what I wanted to cover in the first hour. Let's take our break. Let's do about a 10-minute music break. I'll chill out, and maybe I'll see if Woofy wants to go for a little walk, and I'll see you in about 10 minutes. Whoops, where did that go?